Welcome, everybody. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated, or CFRI. This CF Discovery Series was developed in collaboration with Camille Wasowich, nurse practitioner at Stanford CF Adult Clinic. The series was designed to make vital CF information accessible to the CF community. And before beginning, I would like to note that no information presented tonight is intended to be a patient's arm to lean on in terms of diagnosis or treatment, but this may open doors for you to ask different questions and share information with your healthcare providers. So as always, we urge you, work together with your healthcare team for your medical treatment. Tonight we look forward to our presentation on bone health and disease and cystic fibrosis. Thanks to Genentech for supporting this event. Their support pays for the venue, the refreshments, the studio we have here constructed, and other costs associated with the program. Tonight's program is being produced by your CFRI Live team. That is Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who's tracking questions from our participants. We are live at the Crown Plaza Cabana Hotel in Palo Alto, and I encourage all of you to ask questions, whether here in this audience or part of our online community. Especially a hello out to all of those of you who are in the hospital. Join us. And finally, thanks to our volunteers for serving food, helping with our cross-infection policies, and all the other details that go into hosting the CF Discovery Series. Now I'd like to introduce you to Camille Wasowich, nurse practitioner at Stanford. Thank you, Camille.
Good evening and welcome. Thanks so much for coming, and for those in the hospital, again, thanks for tuning in. As Carol had mentioned, the reason why we started this program was because we felt that there were so many that really could benefit from additional information that they could tune in at any time to. And that's why we're videotaping this, and that's why the program has been slotted as a free educational program. About 9 months ago, I was sitting with a radiologist looking at spinal fractures on a 32-year-old gal who had come in, had fallen, and was unable to do CPT therapy. And I said to her, "This is extraordinary." She said, "She has a spine of an 80-year-old. About 2 months later, the patient ended up getting a chest tube because she had fractured when coughing, secondary again to osteoporosis. When I was speaking with this radiologist, she had mentioned Dr. Laura Bachrach as being one of the premier speakers and very knowledgeable in osteoporosis and osteopenia. And so that is the reason why we decided to talk about this really important topic, because in some ways with medical therapy it can be prevented or at least improved upon, because fractures really are a very important thing and CPT is a necessary thing. Dr. Laura Bachrach started her education at Tufts University in Boston. She completed her internship at UCSF and did a combined residency at both UCSF and Stanford. She was fellowship trained at the Hospital of Sick Children in Toronto and is board certified in both pediatrics and pediatric endocrinology. She's been on staff at Stanford for 27 years. She is incredibly brilliant, and it's my pleasure to introduce her right now.
I need a copy of this tape because my husband doesn't think I'm incredibly brilliant. So, yeah, I'm a pediatric endocrinologist, but for the last 20 years, my passion has been bone health. And you might think that's a funny combination, but I'm hoping I'm going to convince you that it's very relevant for me to care about what happens to people's bones in the first 2 decades of life and then beyond. My interest in CF actually goes back to the beginning of my bone research. When I started out doing research, I looked at 2 populations, young women with anorexia nervosa and individuals with cystic fibrosis. So honestly, my interest in CF goes back a long way, and I've learned a lot, and I hope to learn a lot from you guys if indeed you have questions. So we all know the good news about CF, that survival is now extended and people live much longer, healthier lives. But the complications that have occurred in association with this longevity are very troubling sometimes. They include such things that fall in my domain, such as CF-related diabetes, about which I know you've heard, as well as CF-related bone disease. So I want to present with a case. This would be a typical case, and Cammie brought up a scenario, but this is a similar one. 19-year-old female being considered for the lung transplant list. She had grown along the 10th percentile. She's slightly slim at the weight of the 3rd percentile. Her body mass index about the 10th percentile. She had her periods a bit late at 16, and she's not been having regular periods. Her last period was about 6 months ago. Her disease severity is such that her FEV1 is about 60% of expected. She's been on intermittent glucocorticoids when she has a pulmonary exacerbation, and she has very mild CF-related diabetes. She basically uses insulin only when hospitalized and ill during an exacerbation. Her bone history is that she's had 2 rib fractures with coughing. This is very typical. Back pain now. She's had a DEXA bone density study that shows that her bone density is low for her age. It's more than 2 standard deviations below where we'd expect it to be. Her vitamin D was last tested 2 years ago, and the level was 15, which is below the optimal. And in terms of family history, she has a grandmother who had a hip fracture as an older person. These factors will become relevant as I walk you through how we assess someone with bone problems. In terms of lifestyle, she attends college. She doesn't do a lot of activity, but she's able to walk between classes. So the questions I want to ask you now is, does she have CF-related bone disease? Will this take her off the transplant list? And how should we assess and treat her? So, talking about bone health and disease and CF, the focus of my talk is going to talk about how you build bone strength as a young person, what are the threats, how do we evaluate someone to determine if they have bone fragility or risks thereof, and how do we treat it. This is how I got into this business. The bone bank is really built during childhood and adolescence. And unfortunately, a lot of people wake up, a lot of postmenopausal women wake up and think about their bones, or even women in their 30s and 40s. But in fact, when we need to think about this is throughout childhood and adolescence. Because by the age of 20 to 30, you have basically achieved what's going to be your lifetime maximum bone density, bone size, bone strength. And if things don't go right, what happens is you enter that period of the rest of your life with, if you will, less bone in the bank. So my mission in my area of clinical expertise and research has been to try to optimize the gains in bone up until that adult period. Of course, beyond that time, I want people to hang on to what they have. And those are my 2 areas of focus. So during the time that you're building the bone bank, during childhood and adolescence, bones are changing in size and shape and mass. And each of those contribute to the strength of the bone. It's not just about this quote-unquote bone density. It's how the bone is distributed in the body that matters. And these are the factors that are relevant. Heredity is the biggest thing. Whether or not you have a family history of osteoporosis is very, very important. We think about 60 to 80% of the differences between people in their bone density at peak bone mass is related to their genes. I don't spend a lot of time talking about that when I talk to patients because we don't get to pick our families. I talk about the things we can control, which is body mass, calcium and vitamin D, activity and hormones, and I'll run through these briefly. When I got into this research area, we really felt that only underweight individuals were at risk, because underweight is a reflection of inadequate nutrition, perhaps small bone size, and low levels of the growth factors and low levels of sex hormones. But we are now discovering that if you're too heavy, that is also a risk factor, and we're seeing more childhood fractures amongst the obese children because the bones can't compensate for the added load. So we worry about underweight and overweight individuals in terms of their health. As far as calcium goes, everybody thinks about what you're taking in. But you have to think about the economics. It's a little more complicated. It's also how much you absorb. And this is where your vitamin D comes in. It's very important. You only effectively absorb about 30% of what you take in. But it'll be less than that if your vitamin D levels are low. And then you have to think about what you're going to lose. And you lose calcium both in your stool and in your urine. And one of the most important factors relating to how much you lose in your urine is how much salt is in your diet. Because when you lose excess salt from your diet, you have a bag of chips, you don't need all that salt, the rest of the salt goes out in the urine, it drags calcium with it. So we have to think about all the economics about calcium and vitamin D. Then we think about activity. Now what we know is that inside your bones you have bone-building cells, and they're called stem cells. And they can go down the line to become a fat cell, an adipocyte. And that occurs if you have a relatively sedentary lifestyle. If you have activity, you will stimulate that stem cell to go the other avenue and become an osteoblast, which is a bone builder. And this is why activity is so important in terms of helping to build up bone. In terms of hormones, we think of good hormones for bone as being estrogen, testosterone, and growth hormone, which stimulates the production of the insulin-like growth factors. Those are the good ones. And then we think about glucocorticoids, at least in high dose, as having deleterious effect on bone. So hormones are really important in terms of your bone health. So when we talk about cystic fibrosis-related bone disease, we specifically call it CF-related bone disease. We don't call it osteoporosis, because when we call it osteoporosis, many people sort of fire off in their head thinking about postmenopausal osteoporosis and the factors that cause that. So CF-related bone disease is certainly bone fragility and fragility leading to fractures, but I'm going to talk about CF-related bone disease in the same way we talk about CF-related diabetes, because it's different from the other types of diabetes. Now, we can think about the scope of the problem, in other words, how common is this, in one of two ways. We can think about it by using a surrogate measure of your bone strength, which is called your bone density, and this is typically measured by doing a bone densitometry test called a DEXA. So that's one way of looking at things. But not everybody with low bone density is going to have fractures. So the other way, and in fact the most gold standard clinical way to look at whether or not somebody has a problem with their bones, is whether or not they're fracturing with just the activities of daily living. Bone densitometry is readily available, and I suspect that many of you in this room have had this test done. It is the amount of radiation that you would get from flying from LA to New York and back, even though we can look at every bone in your body. So it's very safe, it's readily available, it doesn't involve putting IVs in, and it's very, gives us good information. But when interpreting bone density, particularly in a patient who may have had slower growth or delayed puberty, you have to take into account these factors when interpreting things, or you're going to tend to overread the extent to which there's a problem with the amount of bone that's present. The recommended skeletal sites to do these bone density tests are different for children and adults. Adults, typically, they look at the spine and the hip region. In children, it's more important to look at the spine and something called the whole body. Interpreting the bone density is also important, and for any health providers that may be listening to this, it's important to mind your T's and Z's. So the software from most bone density reports will report something called a T-score. And what the T-score is, it's a comparison of your bone density, you the person that got on the machine, with a healthy young adult. And a Z-score compares you to somebody your own age. Now, if you are 11 years old, you should not get a T-score. We should not be comparing you to an adult. That would be like saying, boy, that 11-year-old is short. They're not short for an 11-year-old, they're short compared to an adult. And that's exactly what happens if you use a T-score. You want to use a Z-score, which compares you, particularly before the age of 18 to 20, other children or adolescents of their own age. The Z-score and the T-score between the ages of 18 and 30 are virtually the same. So what does it mean? If you have a Z-score or a T-score that's more than 2 standard deviations below the peers that we're comparing you to, that's quote-unquote low bone mass for age. Sometimes people throw out a term like osteopenia or osteoporosis based upon bone density alone. And this is not appropriate. We cannot diagnose osteoporosis in a child, an adolescent, or a young adult on the basis of a bone density test. The terms osteopenia and osteoporosis were developed in postmenopausal women because there was such a tight correlation between the bone density and the risk of fractures that they could do that. But in young people, we can't predict fractures that well from the bone density test, and we shouldn't use that. We can talk about someone having low bone mass for age if they're more than 2 standard deviations below normal, but we shouldn't label them as osteoporotic on the basis of bone density alone. Now, what are the data if you look at the literature on bone density in CF? This is our sort of way of looking at children with CF. What are their bones looking like? Well, in various studies that have been done, 20 to 34%, so as much as a third of them will have a low bone density for age. But the studies that have been done don't always correct for bone size or delayed puberty, so we may be overestimating the problem. The deficits, or how low, the likelihood you're going to have a low bone density, increases with age. So an 8-year-old, a 10-year-old, a 12-year-old is more likely to have a normal bone density. As they begin to go through adolescence, they begin to lose ground relative to their peers, not because they're actually losing bone, but because they're not gaining as quickly as the others. So they sort of get left behind, if you will, a little bit. This is an important point because when we talk about therapy, if the problem is they're just not gaining enough, let's think about ways to boost the gains rather than trying to stop the loss. Now, in adults, a higher percent have been reported to have low bone densities in terms of T-scores between -1 and -2.5. And here, if you do serial measurements of young adults, you can actually document bone loss. So, you reach that peak, we'd like everybody to hold on to it, whatever they have. But what we see in adults with CF is that there tends to be a bone loss of about 1 to 2% a year, which is roughly comparable to what happens to postmenopausal women. So we have two problems. One is boosting up the gains in the young person with CF and preventing the loss in the older person. Now, there are caveats in interpreting this, and I won't go through this in more detail, but whoever is looking at your bone density test needs to be skilled to think about other issues about bone size and delayed growth and puberty. And there's also marked variability. You can't say just because someone has CF, they're going to have low bone mass. This is a very old study that I did at Packard Children's Hospital with the help of the CF staff to recruit. And what we see on the left is the beginning and the follow-up bone density studies for individual patients, females on the left and males on the right. And the dark line that kind of goes up and curves over in the middle is the average bone density gains in young people. What you can see is that there are females and males who are below the curve throughout their childhood and adolescence, but they're still gaining. You see others who start out fairly normal and they're losing bone. Similarly, you see the same with males. So the individual course for the individual patient with CF is going to vary, and that's important to take into account. These are longitudinal data that brings home the point that everybody's course is different. But what you do see, even from the back of the room, is that the majority of patients with CF that we studied in this relatively small study had bone densities that were below the average, but some were gaining at a fairly respectable rate. Now, there is another way to get at bone, and that's where you actually take a little tiny chunk of bone out of the iliac crest, out of the hip region. And what you see if you actually take a little bit of bone and you can hone in on the microscopic amounts of bone there, is that there's less integrity to the microarchitecture within the bone, and I'll show you a picture of what that means. There's less bone, there's less connectivity, and there can be something called osteomalacia, where you have almost like rickets in the bone. And again, the reason appears to be a reduction in bone formation, and we mainly see bone loss in the post-transplant patient. This picture will say 1,000 words. On the left-hand side of your screen, what you see is healthy, normal trabecular bone. And what you see is it looks very much like a sponge, and there are trabeculae or interconnections that work together to give strength to the bone. What you see on the right is that those arms, if you will, of the bone have been thinned and even in some cases narrowed and broken. And what that tells you is you can imagine that if you jar the bone on the right, let's say by picking up a heavy object, or if I walk across the rug here and trip and fall down, that my bone on the right is less able to handle those kinds of strains than the bone on the left. And this is what we can see with the microscopic looks through bone histomorphometry. But the ultimate test of whether or not someone has bone fragility is whether or not they have fractures. And the data from CF show that the common places that patients with CF are going to have fractures are in the spine and in the ribs, more so than in the long bones. By the long bones meaning my femur, my tibia, fibula, my radius, and ulna. Much more likely to have a rib fracture or collapse my vertebrae. And of course that has real implications if you think about trying to breathe with a broken rib or a collapsed vertebrae. So in childhood, there generally is not evidence of increased fracture rates, with the exception of one study. But in adulthood, there is a definite increase in the risk of fractures at the sites that I just mentioned. So the toll of this is that you'll have pain. Obviously, fractures are very painful. It can compromise your breathing, and as Camille pointed out, it can even interfere with your doing your lung treatments. It can cause something called kyphosis, where you're kind of hunched over, which reduces the volume that is available for your lungs to expand and breathe, and may be used by the transplant surgeons as a reason to take you off the transplant list. So it has very serious implications. Now, again, I went through this at the beginning, but let's just go specifically through the threats to bone health in CF. Let's talk about genetics first. Malnutrition, inflammation, glucocorticoids, endocrine causes, and inactivity. Now, as far as genetics go, I mentioned to you in general that 68% of the differences between people is determined genetically. And the best way we get at it is we ask about the family history of hip fractures in the elderly. Because a hip fracture in the elderly is a fragility fracture. So that's one thing. But what about specifically with CF, the CFTR gene and bone? It's really not clear that that in itself is going to cause bone disease. But there is a possible role for that because there are CFTR receptors on human and mouse bone. And there's a mouse model of a CFTR deficient mouse that has low bone mass. But there's a lot less certainty about whether it's the genes related to CF or all the disease-related factors related to CF that leads to the bone fragility. Malnutrition. We do know that if you have malabsorption of fat and calories and vitamins and calcium, you don't have the building blocks you need to build up the bone. And of course, with CF-related diabetes, what you do take in, you may waste some of it through loss of glucose in the urine. And then it's bad enough that you have a compromise in what's coming in, you have an increased demand, because the chronic inflammatory lung disease does cause you to have an increased demand just to maintain your weight. So that's a bad combination. And what we know is there's a very tight correlation between your nutritional status and your bone status. And if you have a low body mass index, that's an indication of your weight for height, and you have reduced lean body mass, those are strongly associated with having a lower bone mass. And in children, they've determined that children with CF can have completely normal bone density for age if they have normal body mass index and normal lean body mass. That makes you feel like if you can just maintain nutrition well, certainly through childhood and adolescence, you could maintain the bones. That's an argument against there being anything inherent in the CFTR gene that causes the problem. Of course, we know that's a tall order. Then there's the vitamin mineral deficiencies. For vitamin D, the recommended level for the 25-hydroxyvitamin D, this is a measure that you should have done at least once a year, should be at least 20, and many people say it should be at least 30. And what we see is that there's a high incidence of patients who don't have adequate vitamin D stores in the body. And as I say, that's critical for maintaining your ability to absorb calcium. But we also think that vitamin D has other roles, maybe keeping down inflammation, reducing the risk of cancer, reducing the risk of diabetes, and there are other things that vitamin D is important for. And the reason the vitamin D levels are low is because you have problems with malabsorption. This is a fat-soluble vitamin. You may have abnormal biosynthesis, and you may not get out in the sun to be able to make it through the skin, and there may be increased clearance of vitamin D. Vitamin K is also something that's important for bone health, and about 40% of patients with CF are vitamin K deficient, and getting enough calcium in is another factor. Then we talk about inflammation. We know that when you have a pulmonary infection, you have high inflammation, and these chemicals in your body called cytokines tend to be very deleterious for bone. They cause a reduction in bone formation and an increase in bone loss. And when you control your infections through antibiotics and improve nutrition and chest PT, your inflammation goes down, and this will help to reduce the deleterious effect on the bone. Then we have glucocorticoids. We know that, especially during times of pulmonary exacerbation, that you need to take steroids. They can have adverse effects on bone by, again, decreasing the formation of bone and increasing the bone loss. But ironically, if you can control the inflammation, which you may need to do during exacerbation with steroids, you actually net may come out ahead. Because the effects of the cytokines that I talked about when you have an infection or inflammation are just as bad as the effect of the steroids themselves. So in some cases, getting things under control through antibiotics and your glucocorticoids may actually be a benefit to your bones. The net effect of glucocorticoids on bone is related to a whole bunch of other factors. So we can't just say because you have to take prednisone or inhaled steroids that you should feel badly about this, because the net effect is going to depend on the balance of all these things. And if the steroids end up helping you improve your nutrition, get more active, and control the disease severity, again, net, you may come out ahead. Now, there are endocrine disorders that are associated with CF. We know that it's more common to have delay in the onset and completion of puberty, and when you have a delay in puberty, you're going to have a reduction in the amount of the estrogen and the testosterone that's so good for bone. We know that the more severe the disease, the more likely you are to have delayed puberty. And in an adult, you may have reached your puberty, completed puberty, but then end up having a reduction in the sex steroids, so-called hypogonadism. Low testosterone is found in different studies between 2% and 88% of men with CF. Between 28 and 73% of women will have irregular periods. And it is related to a combination of the disease severity, and in some cases the glucocorticoids can cause a reduction in the testosterone and estrogen production. And then, of course, the other endocrine disorder that's common in CF is CF related to diabetes. Now, in terms of transplantation, we do know that many people come into their transplant already a bit debilitated in terms of their bones. 25% of patients who are evaluated before transplant have already had a vertebral fracture. And a vertebral fracture in a young person is definitely a fragility fracture. And then, as you go through the process, especially in that first year post-transplant, there are increased bone losses, and they're related to the glucocorticoids and the other anti-rejection drugs you have to take. It's related to periods of time when you're somewhat immobilized in bed, recovering from your transplant, and you may have decreased intake of foods by mouth for a period of time. But again, on the upside, there are studies that show that once you recover from this process, you've removed the diseased lung, you have good lung, there's a potential for catch-up and improvement in bone health at the end of the light at the end of the tunnel. So how do we go about, or how should you go about demanding that your bones be evaluated? There have been consensus statements written about this. And they talk about the pathophysiology, they talk about screening, treatment, and prevention. These consensus statements reflect a convention of experts in the area of CF and bone. I've had the privilege of attending some of these, and we go through everything that's ever been written about this, and then we mull it all together, and we base our recommendations on the best data that are out there, as well as expert opinion. And the U.S. guidelines were last published in 2006. This was the conference I was able to attend and participate in, and it was a really remarkable process. It's also very humbling because sometimes we come up with a consensus statement that is based on the based on the best knowledge we have, but we still wish we knew more. So we're giving the best guess we can based upon what's known, but we obviously have more work to do. There are European guidelines as well, and the European guidelines were just published last year, and they're quite similar but expand upon what the European guidelines were. So one of the areas that's talked about in the guidelines is who needs a DEXA scan, who should have a bone density scan. All adults with CF should have a bone density scan is the recommendation. For younger patients, beginning at the age of 8 to 10 years, a DEXA scan is recommended for those who are less than 90% of ideal body weight, who have an FEV1 of less than 50%, who are requiring at least 5 milligrams a day of glucocorticoids for at least 3 months, if they have delayed puberty or history of fractures or transplantation. So sometimes we do this in younger patients, but certainly not every patient needs to be screened, but every adult should be screened. Once you've done one test, when do you do the next one? And there are recommendations here. If you came out of your first test as an adult with a T or Z score that's about 1 standard deviation away from normal, you don't need another test for 5 years. If your bone density is a little lower, between 1 and 2 standard deviations below, every 2 to 4 years. And if you already have low bone density for age or below -2, the recommendations are for yearly scans. What about treatment? The hallmark of treatment is to address all the risk factors. And I've had many doctors call me up and say, you know, Laura, I've got this patient with this problem and that problem. How much calcium do I need to give them for their bones? And I think, well, calcium's important, vitamin D is important, exercise is important. You have to address all the legs of the stool if you want to improve things. So, obviously, we want to optimize pulmonary function. We want to optimize nutrition. Take a look at adequate amounts of calcium, vitamin D, vitamin K, and ideally target a BMI of greater than the 50th percentile. Now, calcium is what we call a threshold nutrient. What does that mean? As you take more calcium, you gain more bone, but only to a certain sweet spot. Okay? In other words, then taking twice as much as that is not going to do anything for your bones. It only increases your risk of having renal stones because you're bringing too much calcium in. You're going to lose the extra calcium through your kidneys. What is that sweet spot? Well, for adolescents, between 9 and 13, actually all the way up to 18, that sweet spot recommended is about 1,300 milligrams a day. For young adults up to age 51, it's about 1,000 milligrams a day. The upper limits where we worry about it's too much is about twice the optimal amount. So again, there are people who out there think, I heard calcium's good for you, so I'm just going to pop 4 Viactiv a day, and they're going to exceed their limit. So we want to get to be enough, but not too much. How much vitamin D? There really isn't a magic answer for this. You have to actually measure it in your body because everybody's different about how much they can absorb. So we say how much vitamin D? Enough to get you to a serum vitamin D level of greater than 20 or greater than 30. There's a big controversy about that, but at least to get everybody to 20 nanograms per ml. Now, that's going to vary. How much you need in CF is going to vary a lot. And you cannot assume just because you're taking your ADEC or even your ADEC and then some that you have an adequate store. It has to be measured, and it should be measured once a year. Now, if you get measured and your levels are low, you need to not just take twice as much. You need to take quite a bit more for a period of about 6 weeks and then retest. And sometimes you have to repeat that. Now, there are 2 types of vitamin D. There's vitamin D2 and there's vitamin D3. We want you taking vitamin D3. It's ergocalciferol is vitamin D2, cholecalciferol is vitamin D3. The reason for the recommendation for the cholecalciferol is it seems to stay in the body longer. So you can get the same peaks with both the D2 and D3, but it's more long-lasting to take the D3. What about loading? What's optimal skeletal loading? What's optimal work for your bones? You have to figure out where you're starting from. Okay. Now, everybody in this room is moderately active. Nobody in this room is sitting in a wheelchair. We're all able to walk around. If I want to increase my bone density from my moderately active, I can walk around, I have to do high impact loading. I'm going to have to do some jump roping or play basketball or go dancing. Okay? But if I were completely immobilized on the left-hand side of that graph there, I were bedridden, if I can get up and stand for part of my day, or I can be allowed to walk around the wards, that's going to do a lot to prevent my losing bone. So if you're completely immobilized, you're going to lose bone. If you can even stand and do a little bit of walking around the wards, you're going to do yourself so much service in terms of reducing the bone loss. And if you're up and walking around, then you need a little bit more in terms of high-impact activity to build bone. So you have to titrate the advice about activity to the patient. Where are they starting from? And even getting people to stand and walk around a little bit as opposed to complete bed rest is going to do something. We want to avoid immobilization. We also want to avoid overuse. It may not be a problem in this population, but we see young people who are overdoing it. They're over-exercising, they're not eating enough, they're losing their periods on that basis. And if you do allow people to exercise, I virtually have never told anyone, oh, your bone density is so low, I'm not going to let you do any exercise at all. I realize that if I allow them to exercise, if I allow them to go walking or maybe doing a little dancing, they could fracture. I can't promise they won't. And it might slow down the weight gain, but I do know that exercise is such an important way to maintain the skeleton and potentially build it up. Now, drug therapy is, as far as I'm concerned, the absolute last resort. It's only when all these other general measures fail. And people who call me up and ask what dose of Fosamax to give people, I say, wait a minute. Have you looked at vitamin D? Have you had a nutrition consult? Have you taken exercise into account? What we'd ideally like to be able to prescribe, especially to young people, is what we call an anabolic agent. These young people are failing to gain. They're not losing bone rapidly. They're just not gaining as fast as the others. So we'd like to stimulate bone formation. There is a drug on the market called parathyroid hormone. It's sold as Forteo. You cannot use it in somebody who still has open growth plates because it's been associated with bone tumors. Is it worthy of trial in adults? This is my biggest professional disappointment in CF. Because what I did about 7 or 8 years ago is I wrote the company that makes this drug, and I said, I would really like to test offering this drug in young adults with CF, because this is their chance to still catch up. Because even in older people, Forteo will cause bone formation. And the company said, Laura, that's a pretty good idea. So I wrote what they call an investigator-initiated study, and I succeeded in getting Eli Lilly to tell me they would give me the drug, and they would pay enough money that we could do the study. So I went to my adult colleague at Stanford and I said, I'm a pediatric endocrinologist and I can't recruit pediatric patients with CF, but I've got this drug and I've got this grant, and can we do this study here at Stanford? And the young faculty member said, yeah, let's try to do it at a few centers so we can get this study done. And the other centers said, oh, much too dangerous. Can't do that. So the study never happened. Sent the grant back to the company, never took the drug, and I still think it's an important idea to test out. The other thing people have tried is using recombinant human growth hormone. It's been tried primarily in children. Pilot studies, what they show is you can help children grow faster, gain weight, more lean body mass, and in the process of that, the bones get better, but very small studies and only in children. And again, my disappointment is we haven't tried the Forteo systematically in adults. Then we have anti-catabolic drugs, and these are the most common ones. These are the ones that prevent you from losing bone. So if you're not gaining, at least let's hang on to what you got. And there's a couple of different categories. One is sex steroids, and certainly giving estrogen or testosterone is important if you're an adult who doesn't make enough of your own. That's a really important thing to give back to prevent you from losing bone. And we consider it in kids who have significantly delayed puberty to kind of boost them, get them going. The other category of drugs are called bisphosphonates. So this is Fosamax, this is zoledronic acid, sold as Zometa, this is Sally Field's drug, when I forget the name of it. But anyway, these have been primarily tested in adults, and we use them in children only as in terms of compassionate use. If someone's actually having fractures, we've used them in pediatrics as well. There was a Cochrane review. This means they looked at every study that ever looked at bisphosphonates for CF-related bone disease, and they found only 5 what we call randomized controlled trials. These are the gold standard where you say, we'll randomly say whether you get the drug or you get the placebo. And there were a total of 145 adults with CF, and all these studies combined. And only one of these studies enrolled lung transplant patients. And they used different drugs. There were some oral drugs and there were some intravenous drugs. And the outcome was the bone density went up at the spine and the hip, but the fracture rates were unchanged in these randomized controlled trials. And there were adverse reactions. There was bone pain, there was flu-like symptoms, which seemed to be milder if you were already taking prednisone for your CF. So it's really not clear on the basis of these limited data that this is the be-all, end-all in terms of treatment, but it's really about all we have in our toolkit right now. The adverse effects when you take these drugs either orally or by intravenous, the most common side effect is you just feel awful for the first few days. You feel like, truck ran over you, achy bones, achy muscles. If you don't give adequate calcium and vitamin D, you can also have a low calcium, hypocalcemia. And if you're taking it orally, it can be upsetting to the stomach and to the esophagus. But doesn't seem to be as much of a problem in younger patients in terms of some of the other things they've worried about, avascular necrosis of the jaw, where you get these non-healing mouth ulcers or femur fractures that are atypical. But there is concern that we can overdo it, and there's a lot of discussion about that. There are also, one of the other reasons that people tend to avoid it in young people is that they worry about what would be the birth defects. If you're a young woman who takes these drugs, what could be the potential effects on your offspring? Because the drugs get locked into bone, and they're there for years, and they come out of bone. And when they come out of bone over time, they can readily cross the placenta, and they cause bone deformities in rats. The human studies are quite reassuring that this doesn't have the same effect. But if you are using these drugs and you are a young woman, it is important that you're using effective contraception and that you're being counseled about the uncertainties in this area. Not obviously an issue for men, but potentially for women. So when to consider the use of these drugs? The United States guidelines, 2005, said to consider if the T-score or the Z-score was less than -2. The European guidelines, I think, are better because they go beyond just treating the bone density, which I think is not a good thing to do. In adults, they talk about people with a low trauma fracture. A low trauma fracture is a fracture that occurs from standing height or less. So again, if I walk over to pick up my Diet Coke, trip on the rug, hold out my arm, and break my arm, I've had a fragility fracture. So that's a low trauma fracture. A spine or hip bone density less than -2 with ongoing losses. So here's a situation where you're not taking one bone measurement, you take the measurement and then you can show that every year you're losing a lot of bone. Or if you're waiting or you're just had a lung transplant. That would be another group to treat. Or if you're about to start a 3-month course of steroids, because we do know that the acute reaction to glucocorticoids is typically to lose some bone. So if your bone density is already at -1.5 and you're going to have at least 3 months of steroids, that would be another indication. Again, these are generally opinion-based guidelines. Now, in children and teens, the recommendations are much narrower, bone density Z-score of less than -2, and you've had fractures. Or if you're waiting for transplant or you've had a transplant, or children who are on chronic steroids and have a low bone density. These are the recommendations from Europe in 2011. They sound pretty reasonable to me. It's certainly better than the U.S. guidelines. So I'm going to go back to the patient that we started with, because now you guys are experts. Does she have CF-related bone disease? Well, she has a bone density Z-score of -2.1, so that's low bone density for age. This is more than 2 standard deviation below normal. She has many risk factors. She had a low FEV, she had a low BMI, she had a family history that was positive for a hip fracture, and most importantly, she's had fractures herself. So I would have to say I think she has CF-related bone disease. Will this take her off the transplant list? I hope not. I really hope not, because from what I've tried to tell you is that although she's going to face more risks in the first few months after the transplant, net in the end, she's successful and gets rid of her diseased lung, has a good healthy lung. This may in turn help her bone density. Her low bone density and prior low trauma fracture should not be an absolute contraindication to transplant listing. That's the European guidelines. I think hope somebody writes that down, because if somebody tells you you're not a candidate for transplant because you've had low bone density and prior trauma, then a trauma fracture, then I would refer them to the European guidelines and say that shouldn't be used as a reason to take you off the list. So her next steps should be to evaluate her vitamin D level. She hadn't had that done for 2 years. That's from my perspective, disgraceful. This is something that should be done at least yearly, and it ought to be addressed. It should be systematic. She should have measurements of her sex steroids. She's not having regular periods, and it may be at this point she's going to benefit from some estrogen. She should have a GTT. We really ought to know where she's at in terms of her glucose intolerance at this point. And she's having back pain, so we ought to do a lateral spine film. Let's see if she's had vertebral fractures. We know she had the rib fractures, but maybe that back pain means that she's had vertebral fractures. In terms of intervention, she needs some serious help to improve her body mass index, optimize her vitamin D and vitamin K. And again, we shouldn't poo-poo these things as, oh, that's very old hat, that's just not going to make a difference, because it does. We should address her low FEV1. We may need to consider some sex steroids. We may need to give her some insulin. Insulin and improving her nutrition can really help her bones. And at this point, I would not initiate bisphosphonates until we've taken care of all those other general measures. But she deserves a careful look at her bones and a bone tune-up. So in summary, in terms of bone disease and CF, we know that the skeletal risks increase with age and disease severity, and I want to underscore that because I don't think there's something inherent to the CF itself. It's related to how the disease progresses. So it's not the CFTR gene, at least as far as we know right now. So we need to do everything we can to keep people well. There are myriad threats that can cause a failure to gain, particularly early in life, and increase bone loss later in life. And with careful attention to nutrition and pulmonary function, diabetes, hypogonadism, that's the key first line to therapy, and drug therapy only if these general measures fail. With that, any questions or discussion?
Wow, what a lot of wonderful information. I'm going to take the microphone to whomever would like to make a comment. Is our microphone on? Okay, very good. So we have online listeners who right now are still absorbing the questions in the audience.
So I was thinking about what you said regarding your clinical trial that you were interested in. And based on the information that I heard, it's age up to 30 for reestablishing or enhancing their current bone status. Is the drug that you referenced the only drug that can facilitate that?
Just in case the question didn't come through on the microphone, I'm going to repeat it. The question is it really only till age 30 that you can improve upon your peak bone mass? That is generally true. What is marvelous about Forteo or parathyroid hormone is it has been shown even in postmenopausal women to allow you, if you will, the fountain of youth, to actually lay down new bone. So this is a drug that potentially could be used in somebody past the age of peak bone mass. Naturally, in terms of the life cycle of the bone, most bone is gained by age 20 in most individuals. So you're sort of at your lifetime maximum with some very minor changes in between 20 and 30. But if you took Forteo or parathyroid hormone at age 25, 45, 65, in theory, you should be able to increase bone, and certainly it has been used in even postmenopausal women. It's typically used for a short period of time, around a year and a half. And during that time, there can be dramatic gains in bone density. There's a black box warning, meaning we cannot use it if somebody still has open growth plates. For girls, that's usually till they're at least 14 to 16. For boys, till they're at least 18 years old. That's why I wanted to try it in CF. No one has shown that it would work, but there's every reason to think that if it works in postmenopausal women, it would work in CF patients. And you would select patients who had already had fractures, so they were already sort of experiencing the troubles from bone fragility clinically. But it would be worth, I think, a 12 to 18-month trial. And maybe somebody will pick up this idea again. I don't know. It really was a very difficult time. We actually went, in addition to talking to my colleague at Stanford, we actually went to the CF Foundation to sort of float the idea there to see if there would be other centers interested in enrolling patients, because we wanted to pick young adults who had already had a fracture, because we felt they'd already had significant bone disease, and any risks or unknowns because it hadn't been done would be worth the benefit potentially to build up their bones. So maybe, as I say, somebody will pick up upon this idea and go with it. But the company that makes the drug was very responsive to our concerns about this population, and I feel, want to give them a plug because they were willing to support this. But there was resistance on the part of CF communities. Yeah. Yeah.
I have a couple of questions, if you don't mind. What is the amount of steroid that's considered detrimental? I saw a reference to 5 milligrams. Is that kind of the threshold, or is there no
That
threshold?
is such an awesome question, and it's one that's been debated a lot. And it really, really varies so much by all the factors that I listed on the slide. So I don't think there's a magic amount that's safe, and there's not a magic amount that for sure is going to be a problem. Again, you have to balance out your genetic susceptibility. Some people are more vulnerable when they take steroids to having bone problems. Some people are less vulnerable. Some people, if you net improve your pulmonary function and allows you to get more active, it allows you to eat better, it reduces the inflammatory cytokines, you may be on 10 milligrams a day, but doing good things for your bones. So there really isn't a magic number to say that this amount is safe and this amount is harmful. It's really a combination of factors. So I think that's the context I have to put it in, yeah.
I was in your study in 1991, and I thank you for opening the door to this whole thinking. I think 20 years later, I'm definitely feeling the consequences. I fractured on Fosamax and I fractured on Forteo. Are there any higher level drugs than Forteo, and are the intravenous methods kind of the next round of possibilities?
Great question. There's no guarantee that with any of these therapies you will prevent all fractures, but you do reduce the risk with these drugs. So of the anti-catabolic drugs, the ones that prevent bone loss, the strongest ones in this category are the intravenous ones, specifically zoledronic acid, which is sold as Zometa and have other different names. It's given in postmenopausal women once a year. And they think maybe they can go once every 2 years. It's a very strong, you go in for 20 minutes, you get an infusion. Has a lot of advantages over the oral medication, Fosamax, because oral Fosamax is such a pain to take. You have to get up on Sunday morning, whatever, and you take it with tap water, and you have to wait 45 minutes to even have a cup of coffee. Even then, the absorption is much dicier. So I think the intravenous bisphosphonates have the advantage. You know they're in there. We don't use zoledronic acid in children. We use pamidronate, which is given every 3 months. But I believe, sort of myself, there's an advantage over the intravenous over the oral. As far as the Forteo or the parathyroid hormone goes, that goes beyond, stopping the bone loss, is actually meant to build up the bone. So that is considered to be the best, if you will, the most potent of all the bone building medications. So it sounds like, it's been a stormy course, a lot of risk factors in your case, and despite, getting good treatment, you've still suffered the fractures, which, again, I'm glad you spoke on that, because you know what a toll it takes in terms of the pain, and especially if you've got something going on in your ribs or your back, it's miserable, and, it's a huge toll. But it sounds like you've tried the best, and there really isn't anything else at the moment that's on the market. There is a lot of research. There's a lot of different avenues that people are looking at, new agents, but they're not out there yet for treatment. Yeah.
Sorry, one more.
Yeah.
One more question. The recommendation for calcium, 1,000 milligrams a day, is that specific to CF, or is that in general?
No, that's a great question as well. So the question is that enough for everybody? Is 1,000 milligrams a day enough for everybody? That's talking about garden variety, free-range adults who have no other risk factors. One of the downsides for taking steroids is that it does cause you to lose more calcium in your urine. That's one of the effects of it. So for somebody who's got additional risk factors, you might go much more looking towards the upper end. Now, again, I think that upper limit holds for everybody. You don't want to exceed 3,000 units a day, but if you took a supplement of 1,000 in addition to what's in your diet, and let's say got to 2,000, that probably would be a safe place to be because, again, there's added challenges. But the other part of the calcium story, of course, is the vitamin D, is the salt in the diet, and things like that.
Thank you.
Mm-hmm.
Hi, I had a question about the salt and calcium you were talking about. Could you explain that a little more?
Yeah.
Because I know, people with CF, we need to eat more salt, and I tend to just dump salt on everything I eat. And so, how do you measure if you're eating too much or not enough, or how does that work?
It's a great question. How do you know how to get enough calcium in to compensate for the salt? A lot of people don't know about or think about this interaction between calcium and sodium in the urine. It simply is a renal fact of life that for every X number of molecules of sodium that you lose in the urine, you drag calcium with it. It's been well worked out. So for somebody who is on a high salt diet, it is important to increase the amount of calcium taken in. There isn't a practical formula that I can give you because if you're just salting your foods, you don't know exactly what you're getting, and you're not going to go through the ritual of analyzing every little molecule of salt. Plus, you're going to have some salt loss in the sweat as well. So that's not going to be dragging the calcium the way that the salt in the urine does drag the calcium. But this is well established, and they've looked at, what we worry about is the global American population. There's a lot of, let's say, kids who are out there eating their hot Cheetos, which are very salty, and they're not taking in much calcium, and it's a double whammy because they're not taking in very much and they're losing a lot of what they've taken in. Anyway, I would say in a situation like this where you are encouraged to have a liberal salt intake, that again, moving towards the, let's say the 2,000 range in the calcium intake instead of the 1,000 milligrams per day as a goal would be a reasonable thing to do. But again, you don't want to exceed the upper limit.
So if you've had the bone scan and you find that you're a few standard deviations below what you want to be and you're working back towards it, how much could you hope or expect to see an improvement when you have follow-up scans?
Yeah, that's a great question. Again, it depends a little bit on your age. If you're my age, you don't expect any improvement. You're just happy to hold the line, okay? But that's really important. And again, I think we have to, have appropriate goals. So for an adult, what you want to do is prevent significant bone loss over time. If you're an 8-year-old and you get good nutrition counseling and you have a good growth spurt a couple years later, you may have a significant gain. But I think, again, if you're looking at serial measurements in adults, what you're looking for is to kind of hold the line. Where you can actually see gains, actual net gains, is when you're getting into the drug therapy, for example, with drugs like Forteo that I mentioned to you. But I'm not going to flash back to the slide I showed you, but I will allude to it. I showed you a really old slide for the study that I did, thanks to people like in our audience here. And what we found is that surprisingly, some people in their late teens or early 20s that we didn't expect to be gaining significantly at all were having these big jump ups. And I remember one young lady, I could clearly trace it. She didn't get any estrogen supplementation until she was 18. It just had been kind of overlooked, and she wasn't having menstrual cycles, hadn't completed her puberty at 18. We felt, okay, that's waiting long enough. So we put her on an estrogen supplement, and in the first year or year and a half that we followed her up, she had 5-6% gain, which is a lot of gain. So it was a late gain. She was a late grower. So it is possible through attention to these general measures in some young adults that you can see these gains. But again, when you get to be 35 or whatever, if you can hold the line, we're happy about that. Yeah.
I was thinking about what you said regarding our age, and for us, the transition is difficult. That's 17, 18 to about 25. A lot of our patients are underweight. A lot of our patients are delta F508, which means they're pancreatic sufficient, and many of which are diabetic. So my question to you is, do you think that you would have the best bang for your buck if you focused your drug therapy on those that were diabetic with an A1C of 7, in addition to being low weight, actually pulling a profile? So they're a diabetic, because truly her question is extraordinary. How much improvement can you really get?
Well, what I would like, and the people that I want to say this to aren't in the audience, but what I would like is some of my pulmonary colleagues to remember that patients with CF have organs in their body other than lungs. Okay? I would like them to think about their bones, their ovaries, their testicles, their glucose metabolism a little bit more sometimes than I think sometimes happens. I'd like them to remember the vitamin D levels. I'd like them to value their nutritionists immensely. I'd like them to value their physical therapists. And I would not like to target any group. I would like to target everybody with CF. And I would like to target people from an early age in a very aggressive way to optimize the, I think all the things that I'm talking about in terms of general measures, they're just so important for every patient, for every perspective in terms of quality of life. But the earlier and more aggressively we go at this in CF at a young age, the more we can build the bone bank. I remember being in Sweden and talking to, this was many years ago, so when I actually did active CF research, and I don't do this anymore, but I remember being over there and asking them about osteoporosis or CF-related bone disease in the Swedish population. They said, what? They said, the guy said, I have one patient who's had a fracture. And I said, well, what is so different about CF in Sweden? And they had a newborn screening program. This was going back many, many years. Very aggressive nutrition and very aggressive treatment of pulmonary infection very early on in life. And this aggressive approach to maintaining overall health, nutritional health, bone health, had resulted in, he looked at me blankly when I talked about CF-related bone problems. And again, I was mostly talking through adolescence because that's what I know the best, but, I did talk to adults with CF when I first got into this business, because everybody used to be housed together on McElroy, and I got to meet everybody, no matter how old they were. But it was really interesting to me to see the difference. So again, that would be my vision. Maybe that sounds idealistic, but I would rather not target one group. But the answer to your question is maybe you would see more differences if you start out with a worse place, but I'd just like to bring everybody up to a better place.
I have a quick question. Do you see any potential for stem cell therapy aiding the situation with bones that are kind of going downhill and improving bone health?
That's a great question, and definitely beyond my area of expertise. I'd love to hear what the stem cell people would say. I honestly don't know. I do think it's really interesting to think about the role of CFTR, and again, it's, whether there's something inherent in the gene itself that's a problem, or is it just all the problems that get, manifest as a result of that? And I feel like it's much more, the fallout from that. And for patients with CF who manage to have a milder course, similarly the bones follow a similar milder deficit picture. But I don't know, that'd be a great question for those who do stem cell.
Okay, I would like to give a warm round of thanks to Dr. Laura Bachrach. And as you know, we're here at the CF Discovery Series live in the Crown Court Cabana, Palo Alto, and we hope that you'll join us again in 1 month, which will be the second Tuesday of June, June 12th, when we will be talking about eating and eating-related issues with cystic fibrosis. In the meantime, a reminder to all of us that CFRI is producing several presentations that are not only streamed live, but also available after the fact on demand. You can check out our website and see that we have a bit of a library of these discussions. On May 23rd, Dr. Jeff Wine of Stanford will be talking with us about the most recent findings and discoveries, new medications that address the CFTR gene itself, including Kalydeco or Kalydeco, and their recent news about perhaps being able to broaden the audience that they can support with Vertex can support with that drug, and other pharmaceutical companies exploring the same kind of science so that we can all improve our health. Thank you very much for joining us. I hope you all have a good evening.